Hi, everyone. I am Kelly Shanahan. I will be facilitating this session. And I'd like to share a little bit about my story. I am a physician, an OBGYN, or at least I was until I was diagnosed with metastatic breast cancer 5 years ago, 5 years after my early stage diagnosis. I have estrogen receptor positive bone metastases. Despite my facilitating this brain met session, I don't have brain mets, but a lot of my friends do, and I'm glad to see all of you here. I like to say that I'm living with metastatic breast cancer because I have cancer, but it doesn't have me. And I hope that's the way that you all feel. It is a really, really crappy thing when we're handed this diagnosis. But thanks to people doing research into this disease, we have a lot of hope. I like to call myself a realistic optimist or an optimistic realist. I am positive that I'm going to die from metastatic breast cancer. I am positive that it's going to happen sooner than I otherwise would, considering every woman in my family has lived well into her 90s. I am also positive that I am going to live each day to the fullest. I have a 20-year-old daughter just down the road at Chapman University, and she graduates next year. And I'll be damned if I miss that graduation, because one way or the other, I'm paying for it, and I want to be there for the party. It is my great pleasure now to introduce Dr. Frank Su. He's a neurosurgeon at the UCI Chow Family Comprehensive Cancer Center here in Irvine. He's a fellowship-trained surgeon, professor, and department chair of neurologic surgery at UC Irvine. Now, I told you I'm a doctor. So 4 years of college, 4 years of medical school, OBGYN is 4 years of residency, neurosurgery is double digits. So this guy has he's like 12 now, so he's been in school since he was about 3. He specializes in cerebrovascular, minimally invasive, and open skull base surgery. So when, people joke around about, he really is the neurosurgeon, yeah. He has extensive expertise in radiosurgery and functional surgery for movement disorders, deep brain stimulation, and epilepsy. And those of you that have brain metastases may have had some of these radiosurgery procedures done. He was also recently acknowledged on behalf of the Orange County Medical Association for the Physician of Excellence Award in 2018. So now please join me in welcoming Dr. Su, and at the end we will have time for questions. Thank you.
Thank you, organizer of this committee. This is really impressive conference. And I want to tell you that we neurosurgeons are probably the dumbest doctors of them all because it takes us so long to finish training. I compare myself to car mechanics. I don't know how these things work, but I know how to fix it when it goes wrong. So let me jump to my topic. And I think a lot of this you already saw this morning. I'm not going to spend a lot of time talking about the statistics, so I'll kind of go through that fairly quickly. We all know that actually the most common brain tumor is a metastatic brain tumor, not primary tumor, but metastasis. And it's about 8 to 10 people per 100,000 in the US. And there are 200,000 new cases per year. Now, this is all mets from all cancer, not just breast. And 70,000 new brain mets over the remaining lifetime of a cancer diagnosis. And it happens in about 40% of all cancer patients. So it's 10 times more common than the primary brain tumors. And it does create a huge problem when the cancer gets in your central nervous system. It causes a lot of morbidity and mortality. So the 3 big ones are breast, lung, and melanoma. And this is the epidemiology. So again, this, you see, metastatic brain tumor outnumber the primary ones. And breast cancer takes a pretty significant amount of all the metastatic brain tumors. So where do the mets go in the brain? And it's really like real estate. Most of them go to cerebral hemisphere, 80% of them, and 16% occurs in the cerebellum, and 3% happens in the brainstem. This probably has to do with how big the territories and the blood flow pattern in the brain. So the theory is that these cells travels in the bloodstream, and they get dislodged at the favorable spots, and then it started to multiply and grow and form the tumor. There are also a lot of research on why do tumor go to certain places. Now, these are animal models. Certain genetic type will have the tumor go to certain area of the brain, like leptomeningeal, different locations, and all based on the genetic expression. So I said in the beginning, I'm the dumbest one in this whole group of people taking care of patients with breast cancer and metastasis. And this really requires a huge team, and this is a team at our institution, UCI. You have the neuro-oncologist, neuroradiologist, neuropathologist, oncologist, radiation oncologist, and then lastly, the neurosurgeon. But as you can see, the most important person is actually the patient. And this is why we call it patient-centric care, and that's provided by a large team. So what happens when you have a mets to the brain? You start with certain symptoms, headaches, weakness, disequilibrium, vision problems, seizures, sensory changes. And when patient presents with those symptoms, we usually just get a CT scan, and you can see these little spots lighting up. And if you have breast cancer and you have a CT scan like this, that's just really highly suggestive of metastatic disease. And this is the MRI. You can see the picture is better, and you can see more clearly the location and the numbers of the mets. CT scan, you did not see all these little ones, and MRI is more sensitive to pick those up. So the diagnosis made based on imaging, you can use CT, MR, and PET scan, or lumbar puncture, getting cells from the CSF. And the final diagnosis requires histopathological analysis. And the modern treatment is not based on one thing, but based on multiple modalities. Chemotherapy, surgery, whole brain radiation, stereotactic radiosurgery. And you can see how certain things overlap. You may utilize one or two or one or three modalities to attack the metastatic breast cancer. So just briefly, who are the good candidates for direct open surgery? Usually the patients who are doing fairly well with very high living independent living score, Konofsky score. And some of the negative predictors for surgery are for patients with really extensive disease or low functional score. So sometimes we use biopsy to confirm the diagnosis. You can see that sometimes we face patients with more than one lesion, and lesions that involves functional area that's really eloquent that you cannot really resect. And also lesions that's small that you have to be very precise. So we use a needle with navigation to stereotactically get a piece of the tissue, and then we can make the diagnosis. Or sometimes patients are pretty ill from other comorbidities, and we just go for biopsy as well. Resection, that means we go in and remove the tumor en bloc, and that's the cavity. So those are reserved mostly for single large lesions, greater than 3 centimeters, and in areas that we can safely remove the lesions. So when we remove the lesions, it's best to get it out in one piece. If you get it in the little pieces, that can increase the risk of further metastasis. So after surgery, we usually combine this with other treatment modalities like radiation, and I'll talk a little bit more about that. So there's a lot of literature on what type of radiation, how much radiation, but the general consensus earlier on was that whole brain radiation helps. But if you use that alone, it has a recurrence rate of 43% at about 1 year. Now, if you have fewer than 3 lesions, surgery with a post-operative whole brain radiation has a recurrence rate of 23 to 43% at 2 years. So whole brain radiation has been used, and it's probably standard of care in the community that increased the patient survival from 1 month to 4 to 7 months. And some studies have shown that focal radiation treatment, in addition to whole brain radiation, can also be beneficial. So stereotactic radiosurgery, it's really good for smaller lesions, that's less than 3 centimeters. And it has a fairly good success rate, 80 to 95% for local control for smaller lesions. And it also reduces the risk, which is a big benefit for radiating the entire brain, because when you do that, you also cause comorbidities, problem with cognitive function as well. So it also can combine both radiosurgery and whole brain radiation, and that's also very effective. So, and again, I'm not going to talk a lot about this. I think the systemic treatment is being addressed by other conference sessions, but there are 2 major chemotherapy agents that's used. And we have scales and to kind of see how well patient will fare with the disease load, the other factors. And factors are important, are things like whether tumors are hormonally sensitive, HER positive, and you can see the scale here used, that there's 0 to 2, and depending on the genetic composition of the tumor, that your survival will vary. Also, the different scales developed by the National Cancer Institute to see how patients will do. And again, there are these tables that you can look up to see the survival rate after brain metastasis. So when do the neurosurgeon get involved? Well, anytime you have brain metastasis, neurosurgery will probably get consulted, unless it's multiple lesions that you just go directly to whole brain radiation. And again, there are lots of studies out there, and the important ones compares surgery plus radiation versus radiation alone. You can see that clearly if you can resect some of the lesion, there's a definite benefit, 38 versus 8 weeks. Also, surgery plus radiation versus surgery alone without radiation, you can see that there's also a difference. So this is a multimodality treatment. And our understanding and ways of handle brain metastasis for breast cancer, there's a huge need that's unmet. You can see the numbers again. There's a large number of patients in the US. And despite current therapies, the prognosis of the patient with brain mets in the setting of systemic breast cancer remains poor. So there's a lot of work need to be done to improve our care. So there's some more specific information I'm going to show you. If you have HER2 positive and triple negative disease, the likelihood of brain mets is increased. So for HER2 positive cancer, the risk of brain mets is 35 to 50%. And triple negative also is increased. Some of the molecular expression would also increase the chance of the cancer going to the brain, which are the cytokeratin 5, 6, and 14, epidermal growth factor, EGRF, FR, and P53 gene expression. And what does that mean? Well, if you have HER2 positive and triple negative, the time of diagnosis to brain CNS relapse is 1 year in HER2 positive group, and it's less than 6 months in the triple negative group. And control of extracranial disease at time of CNS relapse is 50% in HER2 positive and is uncommon in triple negative. And the median overall survival from time of CNS relapse is up to 1 to 2 years and 35 months. So you can see there are some differences. And the cause of death, HER2 positive group, 50% of them are due to CNS involvement, and the triple negative is rarely due to CNS involvement. And there's some information on how the chemotherapy agent used systemically affect the incidence and outcome of brain mets. And also there's some information saying that because the treatment systemically is getting better, therefore patients are living longer and they're getting mets. So there are other studies trying to look into immunotherapy, whether this is a good thing to treat brain mets. So breast cancer with brain mets, PD-L1 and PD-L2 expression in 53 to 36%. And the survival rate after the surgery can be related to these expression too. So this suggests that there's some role of immunotherapy in treating the brain mets. There are other studies looking at angiogenesis too to see whether we can use that technique as well. So a lot of research happening currently. So for small lesions, less than 4, there are studies looking at radiosurgery plus whole brain versus all brain alone, or radiosurgery plus whole brain, again, looking at versus radiosurgery alone. And you can see the differences. So this is how I look at when a patient comes in, whether they require surgery or radiation. And I use this kind of this framework to help me. So red is patients are good candidate. Yellow is they're probably not good candidate. And you can see factors are single lesion, surgically accessible, good systemic control, and high functional status. Lesions which are large, that's causing a lot of symptoms. And they're also having life-threatening mass effect. So if the patient is in very poor condition or has multiple lesions, they're less likely to get surgery. And as our techniques advance, we have a lot of technology applied to neurosurgery, and in terms of tools, visualization, navigation, imaging using functional MRI, using the tractography, and intraoperative monitoring to ensure the safety of the surgery, and also robotics, intraoperative imaging, and some type of fluorescence to label the tumor so you know that you see that pink spot, that's where tumor sits. Sometimes it's hard to tell with the naked eye or even with the microscope, but with the fluorescence, that helps us to visualize the tumor. Also, if a tumor sits in a very highly functional area, we can do functional MRI ahead of time to know which part we need to avoid to cause post-surgical complications and to avoid the deep white matter tracts so we don't cause morbidity from the surgery. So the goal of surgery is to keep the patient whole after they come out and with the tumor resection. This is the 5-ALA. It is a fluorescent dye that you can use to label. Most of the work was done in gliomas, but we're beginning to use that in metastasis as well. And we use minimally invasive techniques. Traditionally, you can get to any part of the brain, but you have to open the skull. But we're trying to come up with new ways. Instead of doing it this way, we use a microscope. We can get real deep, high magnification through smaller openings. Through the endoscope, we can go through even smaller openings, get to places with the light source right at the tip. So you can do more surgery with small openings. That's the concept. That's the layout of the OR. You can see lots of monitors, lots of machineries, navigation. And these are surgeries that we perform at the base of the skull to remove lesions. You can see we're coming through the nose, taking out these lesions with drills and tools without opening the skull. So if the lesion is accessible, we try to do that without doing the maximally invasive procedures. And imaging really helps us with all this DTI, the pretty pictures, and that really just showing us how the fibers travel in the brain. And again, when you have a tumor, you see the fibers are deep to the tumor. They can be superficial to the tumor, then you gotta go another route. So this guides us on how to do this safer. We also use these little tiny tubes. You can see this is a little tubular device we have. And instead of making big openings, we make very small openings. Using the navigation guidance, we avoid all the major fiber tracts to remove the metastasis in the brain. So we can do a lot more nowadays. These are just some examples. So 55-year-old person with a very superficial lesion. A lot of edema around that lesion. Although the lesion is not very small, there's a lot of swelling around it. This is the post-op picture showing that the lesion was removed. The edema will remain for a little while, but then would also decrease once you take out the tumor, and the symptoms will improve. So this is a lesion, a little bit bigger in the cerebellum, but still very superficial, and that can be removed as well. Actually, this person had 2 lesions. What about this one? Well, this one is a little bit deeper, and it's almost in the center of the head. But using all the techniques that we described earlier, we were able to remove this the lesion, and the patient also did fairly well. So in summary, with improved systemic control, we will see more and more mets because people are living longer. So eventually, the probability of metastasis is higher. And we don't treat this alone. All the treatment for brain mets are multi-modality and multidisciplinary. So it requires a team that I showed you a little earlier. And the goal is to provide, to prolong the survival with local control and most importantly, good quality of life. With the improved research and all the information we have, definitely we are neurosurgeons part of the team. It's a very small part. Most, what we do is very small in terms of taking care of the whole person. So with that, I will, among time, I will open this up to questions. I did talk about whole brain radiation, but I also talked about stereotactic radiosurgery. So if you look at this schema, the whole brain radiation is here. The stereotactic radiosurgery is here. I actually made the circle so big to emphasize that it is very, very important. Well, there's, yeah, I didn't talk a lot about it, but I think you're right. Whole brain radiation has a lot of side effects, right? If you have all these lesions in the brain, if you can, it's best to select them out singly and then hit them one at a time, depending on the size, the location. But if you have more than, say, 15, then you start punching little holes. It's going to add up like a whole brain radiation. But we try to, oh, then definitely, you definitely wanted to do stereotactic radiosurgery. So. Well, I mean, the hope is one day we'll all be out of jobs, that you don't have to do surgery anymore, and radiation or some drug will come and take our place, a robot or something. Yeah. Yeah. So majority of the patient we see will have singular lesion or multiple lesions, and smaller percentage of patients, not a large percentage, will have leptomeningeal spread. Well, so the idea is if they are really diffuse, then it's hard to hit them with surgery or radiation, like, in a small focus. Yeah. So the tumor can sit in the brain. Leptomeninge is the covering of the brain. So if these tumors travel and they see the CSF, it's kind of like you put some salt in the soup and the whole soup is salty, and they can spread to different parts, and they usually show up on the covering of the brain. Yes, and it's connected to the spinal cord. So yes. So Omaya is one good way because the drug, which remains, and they actually, there are several agents that we're using. It's not just one. Yeah. Well, so the idea there is blood-brain barrier. A lot of the drugs actually don't get through, and there are new techniques now, either radiation or focused ultrasound, that those are techniques that open up the blood-brain barrier for a temporary window for the chemotherapy to get in, are being studied. Yeah, so the immunotherapy is the hottest thing, right now for gliomas. And at UCI, we have several studies for GBMs, high-grade gliomas. For Mets, I think we're still kind of in the beginning phase. There's not a lot of good trials yet, but I think we're getting close. But gliomas, definitely immunotherapy is taking off. Those are more considered to be bony metastasis. But if you get lesion in the skull versus like lesion in other places in the body, that's getting a little bit closer. But it's probably a different mechanism, like similar to more similar to bony metastasis versus a direct CNS metastasis. I don't know the answer to that, but what I do know is they are metastases in patients who are good for 10, 20 years, and that still somehow happens, you know. So at what point do you consider yourself safe? I don't know, but the probability will drop the longer you're disease free.